Good afternoon again, and welcome to the Men's Health Network and the Congressional Men's Health Caucus joint briefing on CHIP, the Children's Health Insurance Program. My name is Fadich, and I am the Vice President of Men's Health Network. We are a nonprofit organization based here in Washington, D.C. We have spent many years working closely with the Congressional Men's Health Caucus and our co-chairs, Congressman Markwayne Mullin of Oklahoma and Congressman Donald Payne Jr. of New Jersey. This is one of the many briefings that we've collaborated on this year, and so we're looking forward to having your bosses join the caucus as well if they're not already members, and we'll talk a little bit about that later. Today's briefing on CHIP is discussing what is currently covered for boys and girls who are enrolled. CHIP serves uninsured children up to the age of 19 in families with incomes too high to qualify them for Medicaid. States have broad discretion in setting their own eligibility standards, and eligibility varies across states, more of which you will hear about today. We have a full panel discussion today, so we're going to get started. We will have 1 minute of questions that can be taken after each of the speakers, and then we'll leave the other questions for the end where we'll have a Q&A session. Our congressional members will be stopping by, so when they come in, then we will take a pause from our presentations and have them say a few words. Our first speaker is Dr. Arthur Evans, Jr. He is the CEO of the American Psychological Association. Dr. Evans has been recognized nationally for his work in behavioral health care policy and the transformation of services delivery systems. More recently, Dr. Evans just completed 12 years at the Commissioner of Philadelphia's Department of Behavioral Health and Intellectual Disability Services, a $1 billion healthcare agency. Dr. Evans has also held faculty appointments at the Yale University School of Medicine and the University of Pennsylvania Perelman School of Medicine. Dr. Evans?
Good afternoon. So I'm going to talk about mental health and its importance in the CHIP program. Excuse me, just by way of introduction, Anna mentioned that I was commissioner in Philadelphia. I was also a deputy commissioner in Connecticut. So I've worked in public policy, mental health public policy for the past 20 years up until March of this year. Connecticut, one of the wealthiest states in the country, and Philadelphia, one of the poorest major cities, or has a high proportion of poor children in the city. And I can tell you that whether we're talking about very wealthy communities or communities that have some very significant issues around poverty, that the issues are very similar, and they're the same, they're pervasive. Suicide is the second leading cause of death for children or for young people between the ages of 15 and 24. If you look at our juvenile justice systems, disproportionately the kids who are in that system, particularly kids of color, are kids who have had mental health challenges. And so if we care about children, you have to care about mental health. So I want to thank you for inviting me. Often conversations around healthcare stop at the neck, and we want to make sure that, sure.
We actually have Congressman Mullin, who is here, if you would like to come in and say a few words. I know that you're pretty busy. Oh, come on over, it's okay.
How are you?
Sorry to interrupt
No
you.
problem, no problem.
Hey, guys, first of all, thank you for being here. It is I never take it lightly when people are willing to travel up here and participate in things that they are extremely passionate about. You see men's health being involved in an area that you sometimes ask yourself the question, what does men's health have to do with CHIP? It doesn't cover anything. It doesn't cover anything to do with men's health, but it's health as a whole. It's family. It's talking about setting an example. It's talking about pushing things forward that you see that if it affects us, it affects everybody. Men's health is, we've got to set an example for everybody else that's watching us. You talk about CHIP, and you start talking about the reauthorization, and you start talking about our kids and where that goes for. It goes deep into all of our hearts. You know, the biggest motivating factor I have is my kids, hands down. It's the biggest thing that keeps me motivated, keeps me moving, keeps me in check, and makes me want to make sure I stay healthy is for my kids. I mean, my wife can get onto my case every now and then because I like ice cream more than I like steak and salad. But if you eat fruit with ice cream, by the way, it's healthy for you. It's called a protein shake. And but when we start talking about serious topics that we can all come together on as Republicans and Democrats, and we can put our differences aside and we can come together in whatever form, through the Men's Health Caucus or whatever it may be, and say, guys, we need to be looking ahead on what we need to be doing to strengthen, not just reauthorize, but strengthen the CHIP program. This is a great avenue for it to happen. And I want to thank the Men's Health Caucus for taking a lead in this. I want to thank you for everybody that's being involved and all the sponsors that are helping us push this thing forward, and being out front on the issue, not waiting until the last minute. So many times people wait till the last minute to get involved, but that's not what's happening here. And I love to see a full room, and the idea that we're trying to have an open conversation about it. I like the idea that you guys are giving me an opportunity even to speak. And I hate to make it short, but I really do have to run. I think this is somewhere around my 8th or 9th meeting today, and I think my 4th speaking engagement, including speaking on the floor, because we have a lot of people up here. But I wanted to make sure I came by and just tell you all thank you. And we look forward to working with you. Any way we can help at all, reach out to my office. Give me a call. If you got an idea or a concern, let's work together on this. All right? God bless you all. Thank you so much.
Okay, so let me talk about why we want to focus on children's mental health, and in particular as it relates to the CHIPS program. More than 40% of the children have experienced a behavioral health problem, and I'm going to use the term behavioral health because that includes both mental health services and substance use services, which are a major problem for many adolescents. 70% of the mental disorders occur before the age of 25. When people have mental health challenges, they typically occur in early adulthood or in adolescence. Over the course of a year, 1 in 5 children will experience a mental health challenge, and only 20% of them will actually access services. When it comes to men and boys, the issues are even more challenging. Males are less likely to seek help. Males have a much higher rate of suicide, although girls and women attempt at a greater rate. Boys and men complete at a much higher rate. And so when we're talking about men and boys, even more significant issues. So CHIP is really important because it provides an important source of funding for mental health services for adolescents and children. And those services cover a range of treatment programs that are needed. So typically, a child might need anything from an outpatient treatment program to a partial hospital program to a residential program to an inpatient treatment program. All of those services are covered by the CHIP program and really are essential for meeting the comprehensive needs of children. So the program has sort of 2 tiers, one for those programs who are connected to the state Medicaid program, in which case the behavioral health services are aligned with the federal parity requirements. But even for those that are not a part of the state Medicaid program, most states and most CHIP programs have both inpatient and outpatient services. I mentioned that the program affords a continuum of services. Those turn out to be very important for the kinds of outcomes that children need in those programs if they're going to be successful in school and so forth. I want to give you one example of why this funding is so important. it's clear that when children have access to services, it benefits the children. But one of the things that is probably not understood quite as much is the importance of this funding for building infrastructure in communities. And I want to use the example of childhood trauma. There is quite a bit of research that shows that early adverse events in childhood have a profound impact on the trajectory of children and adults' lives. So children who experience a series of adverse childhood events, much more likely to have physical health problems, much more likely to have mental health problems, much more likely to have social problems, like homelessness and so forth. And so if we can intervene early for those kinds of adverse events, it can make a big difference in children's lives. We use some of the work that has been done in Philadelphia. This is a map of the city of Philadelphia. And the dots that you see there are evidence-based treatment programs in the treatment of trauma for children. The city was able to do that because of the funding that's afforded through, in this case, the Medicaid program and CHIP program. And what the city did, because of this phenomena of trauma and its impact on children, started to screen children in primary care pediatric settings. So over the course of a couple of years, over 30,000 children were screened. About 10% of them screened positive for PTSD. Those kids were then referred to those evidence-based treatment programs and treated. Now, if you know anything about what happens when children have early childhood trauma that goes untreated, it results in things like significant substance use in adulthood. It results in significant social problems, as I mentioned, and it results in significant health care problems that are very costly to our system. So by intervening early, we're able to prevent a life of challenges for people, but it's also good policy because it saves us money on the back end. This kind of work could not happen without the kind of funding that CHIP provides, which allows providers to get the training and to build the infrastructure and capacity to deal with these issues. So in conclusion, very important to include mental health services in these kinds of programs because of the impact that it has. Social and emotional problems is one of the biggest predictors of how children will do in school. And so if we're concerned about children's health in general, this kind of program is enormously important. So thank you very much.
So do we have any questions for Dr. Evans? Okay, well, we will move on then. Next, we have Michael Graham, who is the Senior Vice President of Government and Public Affairs at the American Dental Association. Michael has 38 years of experience in government affairs in federal and state legislative arenas, having worked for 2 Maryland governors and a U.S. Senator. Right.
Well, good afternoon, everybody. I've been with the ADA for 22 years. And during that time, our issues have shifted considerably, so much so that the access to care issue is the #1 issue for the American Dental Association and for our dentists. And CHIP is a big part of that access to care equation. I'll tell you that in 2009, when Congress was debating the Affordable Care Act, I had an opportunity to have a conversation with a very influential U.S. Senator, and I was talking about the importance of dental care being included in the ACA, and he stopped me and he said, well, you know, Mike, we're really focused on health care. And I said, well, Senator, the last time I checked, the mouth was still part of the body, so my flippant response to him got me, okay, let me put it a different way. We're not focused on dental care. So unfortunately, there were aspects of the ACA where we wanted to have dental care included that were not included. CHIP, however, has made some changes that have really enhanced the benefit, and let me just go over some of that as well as some important facts. For example, Some of you may not know that tooth decay is the most common chronic disease among children and teens, and that by the age of 5, 1 in 4 kids will have some type of decay, and that by the time they get to their teenage years, it's closer to 1 in 2. Children with poor oral health tend to miss school a lot more, obviously, than kids without poor oral health, and in fact, they miss school in significant numbers. And interestingly, it's preventable. The vast majority of dental disease is preventable with good education and prevention techniques. Cost is a barrier, we know that. And again, that's where CHIP comes in. Untreated dental disease will have a significant impact on the economy, and I'll give you one example, and that's emergency room visits. Probably don't think about that too much, but over the last 15 years, we've seen the incidence of ER visits go up, specifically for oral health concerns. Now, around the year 2012, we start to see those numbers go down, and we think it's largely to some of the expansion in dental care, Medicaid programs, and CHIP. To give you a real good number, the cost of a visit to the ER for a dental issue is about $860. So when someone goes into the ER and they have some type of oral health crisis, the average cost is $860. How much does it cost? What's the average cost to go see a dentist? About $240. That's a pretty significant savings. We all know that the CHIP program covers millions of kids, about 9 million, and thankfully dental is a big part of that. They're covered, they get dental coverage through CHIP. In 2009, when CHIPRA was passed, it actually solidified that there was a dental benefit in CHIP. Prior to the passage of CHIPRA, it was really left up to the states, and they were not required to provide dental services. The great thing about CHIP is it actually functions very well with Medicaid, and we've seen over the years that utilization with CHIP and Medicaid go up as it refers to oral health usage, and that's terrific. CHIP reauthorization is a high priority for the ADA, and we've been pretty vocal about that. We believe that a delay or significant change to CHIP, as it's written right now, will leave many families with limited opportunities, and it end up being more costly. Bottom line is that dental coverage is important to comprehensive coverage, and that without that coverage, dental coverage in CHIP, it's going to have a significant impact on the lives and the prospects of those children in school and in their employment life later on. Thank you.
Were there any questions for Mr. Graham? Okay, our next speaker is Jack Rollins, who is the Senior Policy Analyst for the National Association of Medicaid Directors, where he is responsible for the association's policy work, including analysis of legislation and regulations impacting Medicaid programs. Jack received a Master's of Public Health from George Washington University.
All right, good afternoon, everyone. It's great to see so many folks interested in CHIP and CHIP reauthorization. So I wanted to provide a little bit of information about NAMD, who we are and what we do. NAMD is a bipartisan and nonprofit association that represents 56 Medicaid programs, so that's the 50 states, the District of Columbia, and the 5 territories. Our members are the Medicaid directors that oversee the Medicaid programs in each of those jurisdictions. And we are essentially the trade association for the Medicaid directors. We serve to develop and promote Medicaid leadership, both at the Medicaid director level and throughout the agency and their mid-level staff. And we also serve as the disseminator of federal activity that's going to impact the Medicaid program, whether that's from here in Congress or from the administration. and we distill the consensus position of the Medicaid directors and communicate that back to policymakers and other key stakeholders. So I wanted to just provide a little bit of background information on the Medicaid program writ large before I get to the interactions between Medicaid and CHIP, just to make sure that everybody is kind of familiar with where we're coming from and appreciates how CHIP and Medicaid interface. So Medicaid is a joint federal-state program. The states are co-financers of the Medicaid program, and they administer the programs at the state level. They're able to have significant leeway in terms of benefit design and covered populations, and CMS, or the Centers for Medicare and Medicaid Services, provides the federal regulatory oversight. Medicaid covers approximately 72 million individuals right now and provides a wide array of services that no other payer really provides. Some examples of that include Medicaid as the primary payer of long-term services and supports for the nation. This is particularly prevalent in terms of services that are provided in the community. We call them home and community-based services. Medicaid also interfaces with folks called the dually eligible, who receive both Medicare and Medicaid services, one of the frailest, most clinically complex, and costliest populations in the nation. Medicaid, as we've heard, is a key payer of behavioral health services. As Medicaid programs are frontline in addressing the opioid epidemic that we've been grappling with as a nation for the past several years. And another statistic is that Medicaid covers over half of the births in this country today. So shifting now to the intersection between Medicaid and CHIP is that Medicaid and CHIP function a little bit differently, although writ large they are broadly similar. First, CHIP has enjoyed some strong bipartisan support since it was established in 1997 and is a key tool for providing coverage and access to care for pregnant women, families, and children. As we've heard, CHIP is a key tool for providing early intervention, which is a great way for improving long-term health outcomes. CHIP is one of the tools in the state's toolbox for addressing what we call social determinants of health, so things that we don't necessarily connect initially with health care, but have a significant impact on health outcomes, such as providing stable housing and access to food services and things like that. One example of the creative uses that states have been able to put CHIP to actually comes from Michigan. I think we probably all recall the lead abatement crisis in Flint, Michigan. Well, the Medicaid director in Michigan was able to use a portion of that state's CHIP funding to finance lead abatement services in the community of Flint, and now it's being expanded to other parts of the state. So that's an example of the type of flexibility and creativity that CHIP provides for states to address key social determinants of health. So a little bit from the administrative aspect, states can administer CHIP either as a standalone program, sort of separate from Medicaid. CHIP can be an extension of the Medicaid program, a targeted expansion of Medicaid financed with CHIP dollars, or there can be a combination of both. Most states use a combination approach. Very few states have a standalone CHIP program. The vast majority have a combination standalone CHIP program and a Medicaid expansion program. So states are able to set CHIP income eligibility levels at a wide variety of levels. Usually it's higher than what is covered under Medicaid for children or families. And some states have CHIP eligibility levels at or above 300% of the federal poverty level, but most fall between 150 to 250%. State-specific breakdowns are actually provided as of fiscal year 2016 from the Medicaid and CHIP Payment and Access Commission, MACPAC. It's a great resource if you're not familiar with it. I would highly recommend looking at their analyses. A little more on terms of data points from MACPAC around CHIP. Between Medicaid and CHIP, nearly 46 million children are covered, and of that, 9 million are covered through CHIP. That's about 5.2 million in a Medicaid expansion option, and about 3.7 million in a standalone CHIP program. So I'm going to get into the policy because that's what I do, so I'd be remiss if I didn't dive into that. So the CHIP program at the federal level sets state-specific allotments that states essentially use their Medicaid match, or the kind of state dollars that are used to draw down federal dollars from that CHIP allotment. Now, when the Affordable Care Act was passed, the CHIP match, in terms of the amount that the federal government gave to states, was enhanced by 23 percentage points above what the state's Medicaid match is. So what that means in practical terms is that under current law, the majority of CHIP financing comes from the federal government. And in some cases, for states that had particularly high federal match set which is based on the amount of federal poverty in the state, some states have their CHIP allotments entirely financed by the federal government as it stands right now. So what does that mean for reauthorization and appropriations for CHIP? As I'm sure we're all aware, current CHIP allotments and CHIP funding expires at the end of this fiscal year, the end of the month, September 30th. But that doesn't align with the budgetary and operational decisions that states have made already. So September 30th sounds like a hard and fast deadline, and in many senses it is from the state operational perspective, but states can continue to spend or draw down their CHIP allotments past that date. Additionally, the Centers for Medicare and Medicaid Services has the ability to reallocate unspent CHIP allotments across the states, which has led to a MACPAC analysis suggesting that states won't be exhausting their CHIP allotments until at the earliest December. So that might give you a sense that there's some wiggle room here, there's some time to delay, you can negotiate on some of the aspects of CHIP policy and maybe make a decision in December. But from the state perspective, that is not the case. So examples of what I mean by that. Every state legislature has already set state general fund allotments for CHIP, for Medicaid, and that's kind of set in stone. The majority of states, I want to say 36, maybe more, assumed that CHIP's current arrangements would, as they stand under current law with the 23 percentage point enhancement, would remain in place. Were that to change, states would have to reconvene their legislatures, find additional state dollars for states that have entirely federally funded CHIP programs. That would be a tremendous challenge. So our ask really is that Congress act sooner rather than later, and ideally before September 30th, to provide states with some operational certainty around what the future of CHIP is and what it's going to look like. The closer that states get to exhausting some of their CHIP allotments, and the more that state actual beneficiaries, children and families on the ground, are going to feel those effects. And the reason is this. States often have in either state statute or regulation a requirement to notify beneficiaries that the coverage you're receiving under CHIP may be changing. It might go away. We might be altering the benefits. You might need to be considering options for coverage elsewhere, whether that's in Medicaid or the exchanges. And in some cases, folks might end up being uninsured. Obviously, that's tremendously disruptive for a beneficiary, and it's a situation that could be avoided if Congress were to act in a timely enough manner. We don't want to end up in a situation where states send out these types of notices, but we all know that Congress will end up refunding CHIP. So states are already in the planning stages for the future of CHIP. Some states have kind of gamed out a work plan which suggests that they would need at least 6 months and ideally a year to wind down CHIP should that be necessary. None of us really think that will be necessary, but it's the kind of lead time that states need to make these operational programmatic decisions and minimize disruption for beneficiaries. So states need commitment from Congress and commitment from the federal government that CHIP will be continuing, and at minimum for at least 2 years, ideally 5 years, and for at least 2 years, the 23% enhancement will remain in place. That reflects the decisions that states have made at the budgetary and operational level and would minimize disruption for states and beneficiaries. I just want to call attention to the announcement from the Senate Finance Committee yesterday around a policy framework for the future of CHIP, which envisions a 5-year reauthorization and a gradual phase down of the 23 percentage point increase. I think that's a positive step. States welcome that, and looking forward to what might be coming out of the House. Thank you.
Were there any questions for Jack? Okay. Our final speaker is Matt Eyles. I'm sorry, yes. No problem.
Thank you. I really appreciate your presentation. And I was just wondering, we heard about the importance of including mental and dental care for children. Are there any improvements in terms of strengthening the CHIP program that you would recommend to ensure that those services are?
I think that from the state perspective, one of the best ways to Oh, I'm sorry. The question was, we've heard a bit about the importance of behavioral health services and dental services in CHIP, and if there were any recommendations for how to strengthen the availability or accessibility of those services under the program going forward. I think one of the best ways to do that from the state perspective is to ensure that states continue to have the flexibility under their CHIP allotments and the structures of the CHIP program to leverage CHIP dollars to either build infrastructure for these types of providers, leverage them in creative ways. My example of Flint is one way that states can have current flexibility. So I think the best way is to maintain and enhance the flexibility that states have to be creative with their CHIP funds. And one way to go about that is to think about CHIP as part of a larger state strategy for delivery system and payment reform. And that might entail value-based contracting to incentivize additional enhancements to primary care, behavioral health integration of dental services into an overall benefit. Those are some high-level examples off the top of my head.
Which we would strongly support.
Yeah, go right ahead.
That you can never treat your way out of dental disease. You can never get ahead of it. About 20% of the population has 80% of the costs. Our strategy has been, I guess I don't need that close, huh? Our strategy has been really to focus on prevention and education. You've got to get ahead of the problem. So we would like to see greater emphasis on programs that promote prevention and education so that early on, as I mentioned before, 1 in 4 kids by the age of 4 suffer from some tooth decay. So we've got to get to the parents and we've got to get to the kids early on, talk about the importance of oral health. And that's how we'll end up reducing costs in the end and saving a lot of missed school time and problems down the road for these kids when we're talking about their teens and even employability.
Okay, great. Our last speaker is Matt Eyles, who is the Executive Vice President of Policy and Regulatory Affairs at America's Health Insurance Plans. At AHIP, he leads government programs, state policy, and product policy departments, and a team focused on broad health policy issues. Matt joined AHIP from Avalier Health, where he was the Executive VP for Consulting, Strategic Communications, and Health Reform.
Good afternoon, everyone. Thanks so much for having me, and I'm proud to back cleanup on this illustrious group here. And I'm going to try and tie some things together, building on what the other panelists said. My colleague just handed out a few brief slides that I'll review. And let me just start by saying it's so nice to be able to talk about a positive healthcare story. CHIP really is. Rather than have to talk about what's going on in the individual market or cost-sharing reduction payments today, I'd much rather talk about all the good things that are happening, particularly with CHIP. And just to build on what some of the other panelists said about, so what does CHIP cover? We know that it can rely on the Medicaid program, but there's alternatives that the states can choose. And just to sort of highlight some of the alternatives are some benchmarks that states can use, whether it be the Federal Employees Health Benefits Program, they can look at state employees' health benefit programs, and they can look at the largest commercial HMO in the marketplace. And to some of the earlier points, these are really mostly combination programs. There's only 8 states that offer them only through Medicaid. The vast majority offer them sort of as combination. And on the next slide, just to highlight a little bit about the role of private health plans in CHIP. It really is the dominant way that most CHIP benefits are delivered to children. About 80% of covered individuals, so about 7 million or so, are covered through private health plans. And AHIP, as the organization that represents the health plan sector, including those that offer comprehensive medical benefits, but also supplemental benefits such as dental. We're very focused on the whole health of the individual, and particularly with a pediatric population, looking at things like prevention and wellness. It's so important with this population. And just to highlight a couple of the additional types of benefits that many private plans offer who are providing CHIP coverage, there's just a list here, and it can be things from health and fitness memberships and rewards programs for healthy behaviors to things like bike helmets, child seats, car seats, again, to make sure that children stay protected and we're focused on wellness. In addition, some extra counseling services, whether it be things like nutrition or making sure children with asthma have allergy-free bedding. I mean, there's a lot of things that can be treated within the home that might not be directly related to healthcare, that are very important to make sure that children have a safe place at home, a healthy place at home, and plans are willing to make investments there because they realize the longer-term benefits. From a value perspective, CHIP is one of our most valuable programs, and it doesn't matter what state you're talking about from around the country. There are great stories about how CHIP is leading to better outcomes for children. And so some of the highlighted ones, whether it's in Oregon or New York, California or Kansas, children are better off because of CHIP, and it's a great story, again, across the country. Just finally, we know that we're on the cusp of reauthorization where the program needs to be reauthorized, hopefully by the end of the month. AHIP is very supportive of reauthorization. We have a chart on the final slide that shows when state allotments, building on work that MACPAC has done, when state allotments for Medicaid funding, for CHIP funding are projected to run out. And you can see that there's a little bit of time, but again, not a lot of time for this program to reauthorize. So we have 3 policy recommendations that we're sharing broadly with the Hill. The first is reauthorizing CHIP for 5 years. We think that's important. The second is maintaining the current funding levels, and I agree that the framework from the Senate that was announced the other day is a really good start. And finally is retaining the maintenance of effort provisions that are part of CHIP today. So thank you for the opportunity to share a couple of thoughts about CHIP, and look forward to any questions you might have. Thank you.
Okay, so we'll open up the floor for questions to any of the panelists. When it's your turn to speak, please make sure to hit the button there to turn the green light on. Do we have any questions to start? Yes. So the question was to speak about the Senate plan.
Sure, I can take that one. So the Senate framework that was announced yesterday was from Senator Hatch and Senator Wyden of the Senate Finance Committee, proposes that CHIP be reauthorized for 5 years with a gradual return to ordinary state match over that time span. The details around that haven't really been announced just yet, but my understanding is that it would be at least maintain the 23% percentage point increase through 2019, which would match the maintenance of effort provisions. And I believe that sometime after 2019, I believe starting in 2020, the maintenance of effort provisions would be reduced for higher income eligibility levels.
Right, and just to add on that, so just exactly right, that the increased funding at 23 percentage points that's under the ACA would stay in place for 2 years, and then the funding would be ramped down. So in 2020 it would go to 11.5%, and then 2021 and 2022 it would go down to 0. The maintenance of effort provisions would be kept in through 2019, which are in current law, but then they would phase out as well. We don't know exactly, what the cost of the package is. It's projected to be maybe about $8 billion or so, but we're waiting to see what it officially is, and we're not quite sure what any offsets might be as part of that package.
Okay, question, yes.
So, the first two speakers, thank you both so much for outlining what some great things are happening, but also this kind of lack of gap we have, especially in dental care for young children and folks. And we're hearing so much good things about what's going on for state innovation. I'm wondering continue the innovation to close some of these disparity gaps, especially on tooth decay, and what we're seeing around addressing behavioral health concerns in young children?
Well, thanks for bringing that up. We are actually seeing some very impressive numbers, and I'll use the Medicaid population as an example, because actually it's even more impressive in CHIP, but I don't have hard numbers. In 47 states between 2003 and I think it's 2012, we've seen 47 states an increase in utilization, so much so that the utilization in Medicaid and CHIP is now rivaling that of the private marketplace. And in some states, a couple of states, I should say, it even exceeds it. So that's very positive. But as I mentioned before, for us, there's a couple of things that we would like to see, a few things we'd like to see cleaned up. The administration of the program, whether it's Medicaid or CHIP, no offense, there are a lot of hurdles that the dental practices have to go through in order to participate in the program. If we could reduce those hurdles to look a little bit more like the commercial marketplace, that would help a great deal in getting more dentists to sign up and participate in the program. And I would say participation in CHIP for dentists is higher than that for Medicaid. About 40% of all dentists participate in the Medicaid program, and there's usually two main reasons for that. One are the administrative hassles, if you will, and the other is the very low reimbursement rate in a lot of states for Medicaid. CHIP is more competitive. If we can get reimbursement rates up so that dentists at least don't lose money every time they see a patient, see a child, that would be significant. Even if they could break even on their costs, they'd be happy to do that. Because right now, I can ask a dentist across the country, do you participate in the Medicaid program? And many of them would say, no, I don't, but I see a lot of Medicaid patients. Well, how is that possible? You don't participate in the Medicaid program, but you see a lot of Medicaid patients? And the reason is the dentist just sees them for free, treats the patient, and then doesn't want to file the paperwork because it's so onerous. These are some of the things that we're looking to change moving forward, both with Medicaid and CHIP, if we can.
What I would say is what Mr. Rollins was talking about in terms of flexibility, I think is really important. Most systems around the country spend most of their money in crisis services, high-end inpatient services, and it means that there's very little left for prevention services. So I think for states to have the kind of flexibility to address social determinants, as he was talking about, is enormously important. We know that addressing things like housing can really offset a lot of medical costs, behavioral health care included. And being able to do more preventative types of work is also really important. Most healthcare systems are set up on, you have to have that diagnosis to get help or to get treatment. And to the extent that there's the flexibility to, as Mr. Rollins talked about, cover other kinds of services, it makes for a much more efficient system. And it actually helps children as well.
Another question? Yes.
So this question is for all panelists, but maybe specifically for Jackie and Matt. There was talks about state allotments all running out by fiscal year 2018. Several of the panelists said there was more of a sense of urgency to get this done now rather than later. Can you just expand a little bit more about what plans the states have in place and why Congress should act at the end of September rather than waiting around until December to get this done?
Sure. So, again, to build on the points that I brought up before, one of the key points is that states have already made budget decisions in their legislatures, and some state legislators will only meet on a biennium basis, so they won't convene again for another 2 years. So if the states are in a situation where the plan where they have exhausted or come close to exhausting their CHIP allotments, and we haven't received assurance from Congress by that point, the states would have to reconvene a legislative special session specifically to address CHIP. And most states, much like states have to be in a balanced budget environment, and there's not a lot of extra money or flexibility or give for states to plug those types of holes, especially if it's a state that has currently 100% of their CHIP allotment funded through federal dollars. In terms of the working plans, it will vary from state to state in terms of what the statutory requirements are and what the state's beneficiary notice requirements are, but there's at least one state that has already made public announcements that their CHIP coverage will look different and will start as soon as October. But in terms of the operational aspects the states need to consider, there could be things like systems modifications to state eligibility and enrollment systems that rely on CHIP statutory authority. An example of that is the express lane eligibility option, which has been of a tremendous benefit in streamlining eligibility and getting beneficiaries into coverage much more quickly, but that hinges on some of the CHIP authorization language. So that's a key example of one operational concern that is top of mind for states. Additionally, states may have to modify or even terminate managed care contracts or contracts with other eligibility enrollment systems or call centers. And these are the types of operational details that require significant lead time for states to minimize disruption from a state procurement and operational level. So those are some examples of the types of things that states are gaming out right now, and the timelines in most cases are at least 6 months, and in some cases up to 18 months.
Great, and I'll just add, with the chart at the end, building on what Jack was just saying, the health plans that operate in CHIP, really, the state is their customer. And they really want to make sure they're serving the state well, but then it's really who's going to be affected if these operational issues aren't addressed because it's not reauthorized and adequate funding. I mean, it's going to be the children at the end of the day that are hurt because there are breaks in coverage and gaps in coverage. And, the alternative may be an individual market plan that is out there, but it's probably a lot more expensive, has a lot higher cost sharing than what you see in CHIP. We have some statistics in some of the briefs that were included in your package. So it's really important that we do it in the short term so we don't have this disruption, so that states have the certainty, and most important, that the children at the end of the day are served.
Any other questions? Yes.
Well, I don't know if the program, when it comes to mental health systems and access to care, excuse me, a lot depends on the leadership in the mental health system. And issues like stigma are issues that really have to be taken on by advocates and leaders within the system. I think to the extent that, from a policy standpoint, to the extent that services are easy to access, to the extent that there is flexibility in where people go to get those services. For example, if services can be integrated and embedded within primary care, that's a really important way for people to get access. It's less stigmatizing often, and people are more likely to do it. So I think that there are policy things that we can do within the program that can encourage that kind of integration, access, so forth, flexibility. But I think the other part of that is that for leaders within, whatever the city or county, state is, to actually actively address issues of stigma. Some of the work that I was involved in Philadelphia, for example, used strategies like public storytelling events with men who talked about their experiences of having mental health challenges. But a long way in normalizing having a mental health challenge. So those kinds of things, I think, paired with good policy can really open up access for people to get the services that they need.
Yes.
Are there any particular provisions in CHIP for children who identify as LGBT
actually at that?
Actually, I don't know if they're specific, but I think this is again an issue of systems. And in my previous work, we had to create programs specifically for people from the transgender community because most programs, residential programs, particularly for children, are very difficult to access if you are a trans boy, trans girl. And so, there has to be some leadership, Medicaid director, others, around ensuring that the right types of services are there. I don't know if there are specific provisions around that, but those are the kinds of things that can be done with good leadership.
I don't believe that there are specific provisions in CHIP that address the LGBTQ community or children that are identifying as transgender. However, it is a benefit that states have the flexibility to cover based on medical necessity criteria, and there are many states that do provide these services. And from my experience at NAMD, we've helped states kind of navigate those issues and connect with each other on best practices in the area.
And I'll just add that the Section 1557 provisions of the Affordable Care Act that healthcare entities, including health plans, have to live up to are covered. And there was a rule that was issued last year that addressed many of those issues. So it's not specific within CHIP, but the framework of non-discrimination applies.
All right, one final question. All right, well, great. Thank you all for joining us. Again, you all have packets there with you. So inside we'll have information about the Men's Health Caucus, and we welcome you to contact Taylor Hiddle out of Congressman Mullin's office, or contact Jamil from Congressman Payne Jr.'s office, and they'll be happy to get things started for you. If you have any questions, my card is inside your packet. Feel free to reach out to me. Thank you for joining us. Please help me give a round of applause to the panelists. And have a wonderful rest of the week.
Yeah, okay.